So the basic concept of this session is to accumulate a lot of imaging and clinical findings so that we kind of present good algorithms for management of certain retinal conditions. We'll start off with a hot topic and a really capable and research-oriented ophthalmologist, Dr. George Manayat from the Aravind Eye Care Systems in Coimbatore, about his approach to managing pachychoroid spectrum disease, the algorithmic approach to managing pachychoroid spectrum.
Can we have the slides? Sure. Do you have a pointer, please?
Already.
Excuse me? Do you have a pointer? So thank you, Dr. Unni, for including me, and we'll look into the algorithmic approach to pachychoroid disease spectrum. So first to know that the spectrum is ever extending now. Initially started with pachyepitheliopathy, CSC, pachyneovasculopathy, and PCV. Now two new entities, peripapillary pachy syndrome and focal choroidal excavation, has been added to this spectrum of diseases. So common to all this, the imaging features are reduced fundus tessellation and a thick choroid, usually more than 400 microns in thickness, and you have this dilated outer choroidal veins or pachy vessels with compression of the overlying choriocapillaries. And on ICG early phase, you see this early delayed filling of the choroid and the dilated outer choroidal veins or pachy vessels. And in the mid phase of ICG angiography, these areas of choroidal vascular hyperpermeability is seen. So these are the imaging features that is common to all this disease. So now moving to the specific entities, pachyepitheliopathy, which is non-specific RPE changes with or without pigment epithelial detachment and considered to be a forme fruste of CSR and has been seen more commonly in the fellow eyes with CSR. So in this, you see best appreciated on the fundus autofluorescence, these RPE disturbances overlying a hyperpermeable choroid on ICG, and then you see the thick choroid with pachychoroid features which we just discussed now. This entity just need to be observed and doesn't have subretinal fluid, but you can see the features like pachydrusen and drusen-like deposits and RP undulations. And this pachydrusen is different from the regular drusen. They are larger, more than 125 microns in size, and scattered all across the posterior pole, unlike the dry AMD where you have the soft drusen which is accumulated at the foveal center. So these are features of pachyepitheliopathy and needs only observation. Moving to the next entity, that is CSC, is generally a self-limiting disease. As you know, you have a serous macular detachment with a point leak overlying a thick hyperpermeable choroid. So we have the more difficult variants of this disease like fibrinous variant of CSC or bullous variant of CSC with exudative retinal detachment, and this fibrin is usually appreciated by the presence of hyperreflective materials in the neurosensory detachment with or without leaking pigment epithelial detachments. And you see in chronic CSC we have features of diffuse RP disease and leak like the diffuse RP epitheliopathy, and chronic CSC on OCT shows these features of intraretinal cystoid spaces, for outer retinal photoreceptor elongation and double layer sign and PED. And this choroidal thickening that we were talking about may be a diffuse or a focal choroidal thickening, which is best example is a peripapillary pachy syndrome where you have a nasal macular choroidal thickening with nasal macular intraretinal and subretinal fluid. So for example, this is usually seen in older people with bilateral disease, and you can see the peripapillary intraretinal fluid on either side of the optic disc here. So it is very important to look at the autofluorescent imaging to see the peripapillary RP mottling, peripapillary pachy vessels and choroidal vascular hyperpermeability on ICG, giving the diagnosis of peripapillary pachychoroid syndrome. Now coming to the management, usually it's a self-limiting disease. We observe up to 2 to 3 months for the resolution, and if it persists beyond that or if it recurs in eyes with visual deficits, or if the other eye has a permanent visual deficit because of the CSC, or chronicity signs developing like the intraretinal cystic changes and RP changes, or patient needs an occupational other needs for early visual rehabilitation. So the simplest treatment, as you know, is focal laser. It hastens recovery, but it doesn't change the recurrences or the disease in the long term. It is done by doing this basically for extrafoveal point leaks as these with 2 to 3 mild intensity grade 1 to 2 burns given to that area. It hastens recovery, but this doesn't change the disease prognosis as such. So now this is only for extrafoveal leaks. Now for juxtafoveal and subfoveal point leaks, you cannot do this conventional laser photocoagulation, but you need to go for a micropulse laser, subthreshold micropulse laser. Yellow laser is preferred, where the short pulses of laser doesn't damage the RP, but it stimulates the RP. So various studies have shown that for subfoveal and juxtafoveal leaks, these micropulse laser is very effective. But the problem is currently there is no consensus on the parameters, uniform treatment parameters used, and it has to be based on threshold test burn, and has to be it has to be titrated to 50% of the threshold burn now. And coming to the next entity for managing CSC, PDT is the gold standard for chronic CSR, where it causes the long-term vascular, choroidal vascular remodeling, and it alters the disease progress once and for all. And single sitting of treatment in chronic CSC, half dose or half fluence have shown equal efficacy in this disease. And we also have shown that similar to the Western, we have 90% resolution in really chronic cases, more than 4 to 6 months of diffuse RP disease. So, for example, this case with a large subfoveal PED and subretinal fluid in both the eyes of this patient, and angio shows a diffuse RP epitheliopathy leaking pigment epithelial detachments. And this is a chronic case. After the treatment, not only the fluid disappears, but the subfoveal PED also has resolved in 3 months' time. So this is the gold standard for chronic CSR. So now another variant is bullous CSC. For example, it presents with exudative retinal detachment. This particular patient was initially misdiagnosed as uveal effusion syndrome and treated with steroids and vortex vein decompression. When I saw, patient had a reticulolendicular touch. It was so bullous RD. So, and macula off, we had to go for a vitrectomy and endo drainage and settle the retina, and under silicone oil attach retina and then do a fluorescein angiography. And then it shows that on fluorescein angiography, it's a diffuse RP epitheliopathy and choroidal vascular hyperpermeability, giving the diagnosis of a chronic CSR in one eye, and you have a bullous exudative RD in the other eye. So this patient under oil, when you do the angio, it shows this extrafoveal diffuse leak for which the laser was done, a grid kind of laser was done, and then patient goes in for remission and attached retina and silicone oil removal is done for this patient. So we have to tackle such cases with the bullous RD, sometimes surgically as a rare entity, but still you may extreme case to be treated in CSC spectrum. And when we see such cases with cystoid macular degeneration, this is a late phase and of the disease, and you have a poor visual recovery in such case. Another biomarker is acquired vitiliform lesions, or AVL, in the chronic CSC setting. This is a poor biomarker, and if you, even with treatment with PDT, you see that this fluid and PED is persisting here. This is another biomarker which suggests that it's a poor prognostic indicator. So Pachy neovasculopathy is another entity in Pachy spectrum, where we see this occult CNVM or type 1 CNVM with a shallow irregular PED, but in a hyperpermeable thick choroid, and you see this hot spot on ICG angiography. This is a typical Pachy neovasculopathy situation, and this is a patient referred as chronic CSR with subretinal fluid, but you see the pachychoroid features in the other eye of this patient, who has a shallow irregular PED or flat irregular PED overlying Pachy vessels. And when you do octa is very sensitive and specific in picking the deep avascular retina, a filamentous network suggesting Pachy neovasculopathy in this setting, and it is not a chronic CSC. So it overlies the area of flat or shallow irregular PED, giving a diagnosis of Pachy neovasculopathy, not PDT but anti-VEGF therapy with fewer number of injections. So Octa is highly sensitive and specific for this indication. Focal choroidal excavation recently added to the spectrum is a sharp choroidal excavation in a normal looking fundus, and it could be a conforming type or a non-conforming type where there is a neurosensory detachment in the area of focal choroidal excavation. The clinical importance of this is it could be associated with PCV or a CNVM, which could usually type 2 CNVM associated with CNV and with FCE, and it needs only very few injections. Unlike AMD or other diseases, this only a few number of injections are sufficient in FCE related CNVM. The last entity we touch upon is a PCV or polypoidal choroidal vasculopathy, which is serosanguinous maculopathy. You can have serosanguinous PEDs and called as type 1 or aneurysmal type 1, and ICG is still the gold standard in imaging, where it shows these hyperfluorescent nodules with a halo of hypofluorescence, best appreciated within the first 1 minute. Unlike the other CNVM, which causes a plaque lesion in the late phase, it is very important to see these nodular lesions in the first 1 minute. And in the late phase ICG, look for this specific finding, that is the LGH or late geographic hyperfluorescence, which is highly specific in the diagnosis of PCV and not in other types of CNVMs. So now we are moving to non-ICG and non-invasive imaging in diagnosis of PCV with 3 major criteria. The major criteria being a sharp peaked PED on OCT, sub-RP ring-like structure, and on fast OCT, this complex RP elevation is seen on fast OCT. So this gives around 82% agreement with ICG a diagnosis of PCV, and in a newer report, instead of the complex RP elevation on fast OCT, it is replaced by orange subretinal nodule on color fundus photograph. So many clinics lacks ICG and PDT facility, so we can use the PLANET study criteria wherein anti-VEGF monotherapy with aflibercept or brolucizumab can be given monthly, and after 3 months only the persistent polypoidal lesions need undergo ICG and photodynamic therapy. So recent RCT showed that even after 3 months, if polypoidal lesions are persisting, it is good enough to extend the loading doses with newer anti-VEGF therapy up to 6 months, which gives almost comparable polyp closure compared to photodynamic therapy. So I summarize that Pachy spectrum ranges from pachyepithelopathy to PCV. CSE is now a choroidal disease with Swepsore's OCT and ICG angiography, and acute CSE up to 3 months is observations, and then focal laser for extrafoveal leaks and micropulse laser for subfoveal juxtafoveal leaks. But both these entities do not alter the disease prognosis or recurrences and do not modify the disease, whereas in chronic CSE and peripapillary Pachy syndrome, half dose PDT is the current norm in treatment, and Pachy neovasculopathy as well as the FC related CNVM, anti-VEGF therapy and Octa are very important in diagnosing and treating. Anti-VEGF only few injections, and PCV is moving to a non-invasive imaging and monotherapy with newer anti-VEGF like aflibercept or brolucizumab, and persistent polypoidal lesions alone needs ICG and photodynamic therapy in combination. Thank you for your kind listening.
Thank you, Josh. Due to shortage of time, there are 6 talks. After 3 talks, we'll be taking up the question and answers. Now I call upon Dr. Unnikrishnan Nair. He is the chairman of Chaitanya Group of Oyo Hospitals from Kerala. He will be speaking to us on algorithmic approach to diagnostic and prognostication in AMD. Over to you, Unni.
The timer was not fixed for the first talk.
Thank you. So we're just trying to create a small summary on an algorithmic approach to treating AMD. It's too vast to cover, but we'll just go through these points. So we'll be discussing the diagnostic, the initiating and propagating treatment, and evaluating prognosis. So in diagnosis, do we really need, this is just the opposite, do we really need to see the retina now to make a diagnosis of OCT? AMD, the answer is actually no. It's a textbook pattern recognition diagnosis. This is just one simple controversial slide. So at the point of diagnosis, how does the algorithm work? We'll check about location, type, location, foveal or non-foveal or threatening the fovea, that depends on how aggressively you need it. The type, basically, is it a pre-RP or a post-RP lesion, or is it so extensive that you cannot make out? The activity, is it currently active? Is it overtly active? That's a new concept. Is it a smoldering disease that is coming off and on and going, or is it totally inactive? Is it a variant? Is it a typical type of AMD, or is it a variant of AMD? The many variants we see. What is the duration? Is it a new disease, or is it a reactivation, or is it chronic? So this is how to align your thought process basically in a patient with AMD at the point of diagnosis. So the type 2, 1 and pre-RP, post-RP I'm not saying, but if you see something like this, you see a mound, you see a lot of intraretinal changes, a lot of hemorrhages. As I said, even if you don't look at the color picture, you get indications that this is a type 3 CNVM. And here, when you see this, I have got this in the wrong place, but let's skip that now. Now coming to initiating treatment. So these are the headings I'd like to discuss under. When do you start immediately? When would you defer it for some time? If you have a typical AMD and you have signs of activity, which are cystoid macular edema, obviously SRF, hemorrhage, you would start treatment immediately. But when would you defer? If you have nil activity. So what do you mean by that? You're putting it under AMD, but you're calling it nil activity. You're calling it a non-exudative CNVM. That is, it is an OCTA diagnosis. Looking at the picture, there is no CME, there is no hemorrhage, but on the OCTA, you see a subretinal network. So you have a non-exudative. It is not inactive. It is not exuding. That's all. And it's a CNVM, a non-exudative CNVM. So that is your first criteria where you would not treat. You would just observe the patient. These are other pictures here. You see the network. You see a slight double layer sign over there. And the OCTA picks up the membrane, non-exudative CNVM. And on a closer, it looks like a very frilly, lacy kind of membrane. So these are just pictures of the same. We'll just skip this. And coming to, so a non-exudative CMVM is a type 1 growing laterally, not invading the RP in a potential space, and that's how it doesn't exude. What is important is the last line. Up to 15% can convert to an active CNVM in the next 1 year. So that is the importance of diagnosing a non-exudative CNVM. So next, when you have minimal activity, would you defer initiation? So this is an example. You have sub-RP activity. The RP PED is expanding, but there is no SRF. So for all practical purposes, you could label this as minimal activity. There is sub-RP activity. There is not enough SRF or CME to justify anti-VEGF. Anti-VEGF could also hasten towards atrophy if you treat it in these patients by a sudden collapse of the PED. So this would be the second circumstance where you defer treatment a little bit. And then the next circumstance, non-neovascular SRF. You have SRF, but it is not neovascular in nature. 3, if you have fluid on top of the PED, if you have fluid at the edges, the draping of the PED, or you have a blanket between two PEDs, this is called non-neovascular. So these are the examples. On the left-hand side, A, you see fluid at the apex of a PED, but it's stable, it doesn't change. On the second one, you have a that is between the two bumps of the PED, you have a small amount of SRF, and the third is at the edge. So these are the 3 examples of non-neovascular SRF. You are not justified in treating, you can observe. So there's no network in OCTA, but you have the 3 examples of non-neovascular SRF. The next, if you have a doubtful diagnosis, initiating treatment. Here you have elevation, you have a lesion, it looks like, but this on the FAF, you see it hyper-autofluorescent. So this is vitelliform. This is a vitelliform hyperfluorescent autofluorescent. It looks like a CNVM, but it's not exactly. These are the images that came earlier, so not supposed to be there. Hyper-autofluorescent. And this is a differential diagnosis also. Anybody can guess what this is? This is what it looks like this is not SRF. This is what you call a torpedo maculopathy. The diagnosis is torpedo maculopathy. It looks like SRF. It is non-neovascular. It's just like a broad FCE kind of picture. So once we start treatment, you go to how intensive you are. So I like to say that you have less aggressive features and highly aggressive features. The 2 less aggressive features would be the presence of subretinal fluid chronically, without intraretinal fluid, and the presence of multi-layering. And the highly aggressive features will come to that. So multi-layering is supposedly a less aggressive feature. Why? It doesn't bleed, it doesn't rip. The fluid stays for a very long time, the vision is maintained for a very long time, but on the flip side, it does not respond well to anti-VEGF, which is false. It responds greatly to the current anti-VEGFs. That is when the really powerful ones, the multi-layering goes down nowadays. This is another example having laminate. You see the laminate inside the PED. Laminate bodies are the same thing. These are good, comparatively good prognostic. You don't have to be highly aggressive with anti-VEGF. So these are two indications: multi-layering, multi-lamination, and the presence of subretinal fluid alone. You can tend to be a little less aggressive with your anti-VEGF. This is one example where you have to be less aggressive, not because of any other reason. You might cause a severe rip if you are highly aggressive. Persistent SRF. There is nothing called happy fluid or beneficial fluid. There is nothing called beneficial fluid. There is only tolerable fluid. How much can you tolerate? Defined at 200 microns. Why? If you treat it too aggressively, it's not like fluid is good. The photoreceptors are bathing in fluid happily. It's nothing like that. If you treat fluid too aggressively, it will go into atrophy. That's the reason why it is tolerated. And why it is called tolerable when there is no change in visual acuity. You have a stable visual acuity, stable amount of fluid. Again, indication for less aggressive treatment with anti-VEGF. So the two treatment modalities, we call PRN and TAE. I would say reactive, because in PRN you are reacting. When you see edema, you are reacting to it. When you see SF, you are so it's a reactive therapy, and it is escape for disease control. When you have disease, it indicates that the condition has escaped the control and you're reacting to it. Proactive is maintaining disease control. You are not allowing the fluid to come. You're giving an injection before the fluid actually comes. So one is proactive. That is, when you do a TAE, it is a proactive treatment. And the aim of AMD is not to treat the OCT, it is to prevent long-term drop. The worst thing that can happen to you is not presence of fluid, it's the presence of atrophy. So the whole indication, the mindset should be changed that you don't over-treat chronic SRF. So this is the hardest thing. Starting treatment is easy, continuing treatment is easy, but knowing when to stop treatment is one of the hardest points in management. So the ability to stop is when you have stable SRF, when you accept activity with stable SRF, when you see outer retinal tubulations, when it goes to multi-layering, or when you have an end result of extreme RP atrophy, and that requires you to become less aggressive to maintain vision. So this is an example of persistent fluid. You have the fluid, there's no change in the sub-RP activity, the fluid is stable, you can afford. The time is your biggest weapon you have, no? You can wait, you can watch, and we don't use that weapon sometimes. Or when you see degenerative edema, that is thin walled cyst, when you see it, you know that it is not because of activity, it is because the RP barrier has been broken and you have transudative fluid. So that is sensation. Now, this is when you have to, any recurrence of a PED has to be considered as reactivation. It's a very, very simple point. You have a flat thing, but when the PED rises again, activity is coming again. Now, let's look at prognosis, a very big slide. Prognosis depends on location. Prognosis depends on nature of the disease. Whether it is a typical AMD, you've caught it extrafoveally, you've treated it, or is it a variety like RAP, where you're going to struggle with treatment and may end with RP atrophy, or is it a disease like PCV? Of the many varieties, some respond well to anti-VEGF, some don't respond well. So this is some of the large things that don't respond well, and SHRM. SHRM or SHRM is hyperreflectivity material inside the SRF. Why is it dangerous? Some SHRM disappears. Some SHRM remains. It's just so we're calling it the wrong thing. The SHRM that remains is actually cellular tissue, which gets converted to fibrotic tissue. So when we see SHRM, and under each visit it doesn't go away and it becomes more and more compact, you know it's just something becoming a scar. And that will result in poor visual acuity. So this is a SHRM, and when it goes, you see it's still over there. It becomes more and more compact, and then finally you end up in a scar. Multi-layering, as I said, and when you see a scar, you have to assess how to stop treatment, where to stop treatment. You can have two. A scar with activity, that is you see true activity, or a scar with degenerative changes. So here you see a scar, you see fluid on top. You could treat aggressively, but if you look at it, it's very thin-walled. It's persistent. It's not changing. This is degenerative cystoid macular edema on top of a diseased retinal pigment epithelium. So aggressive treatment of this is not required. It's just for your satisfaction. the background RP, the amount of geographic atrophy around the CNV would dictate how aggressive you would be. You can afford to preserve the RP by being less aggressive if the following features, you recognize degenerative CME, you recognize SRF, and you say, let me take a step back and let me not treat this aggressively. The choroidal features. Some of the leptochoroids are the most dangerous diseases to treat because they go into atrophy extremely fast. So identifying a thin choroid, a leptochoroid CNVM is very, very important. So all these features are imaging-based features, diagnostic, prognostic. It gives you features to say things. So the end result, just listen to this please. The end result of AMB, the end result of PCV is not scar, it's actually atrophy. So all our efforts should be to prevent atrophy happening in all these changes, and that is the most important thing. Thank you.
Thank you, Unni, for the overview of the algorithm approach for AMD. Next, I call upon Dr. Parveen Sen. She will be speaking to on algorithmic approach in hereditary retinal dystrophy. Dr. Parveen Sen is the Chief of Vitreoretinal Services from Agarwal Group of Eye Hospitals. Over to you, ma'am.
So I'll be, good morning everyone, and at the outset I'd like to thank Dr. Unni for having put up this very interesting and educative IC together. So the responsibility that he's given me is to tell you the algorithm approach to diagnosing and prognosticating hereditary retinal dystrophies. I'll try to make it as simple as possible. इसी पे लगा दीजिए पेन इसी पे लगा दीजिए
He's telling not to get tensed up.
So I will just take it. You can just take a few questions to Dr. George.
Yeah, DC.
Yeah.
That is less than 2 to 3 months. It will go because natural history is first thing where 60 to 70% of the cases resolve within 2 to 3 months or up to less than 6 months. So you get an idea. Now we have a lot of non-invasive imaging where we know whether the disease is settling down. At least in 2 to 3 months, I don't see 50% reduction of the fluid. Then we go ahead with treatment. So that is first thing. And once you decide to treat, then only the role of angiography comes in. Don't do angiography unless and until now we have good imaging modalities. Angio is only to treat. So once you decide to treat, do the angio. Now, what Unni's question is, if it's an acute CSC, first or recurrent episode, it depends on where the leak is. So if the leak is extra foveal, that is around 500 to 1000 more outside the FAZ, then go for focal laser. If it is not, then go for subthreshold yellow micropulse laser. If it's a chronic CSC, that is 3 to 4 months and persisting, then if no PDT, then we go for either subthreshold laser. If it is a focal leak, if it's a diffuse leak, we go for subthreshold diode laser. Large spot subthreshold diode laser. What we used to call as TTT earlier, but then we don't do TTT, but we do a multi-spot, large spot subthreshold diode laser with 50% of the threshold energy.
So thank you, George. Back to ma'am for a talk.
Yeah. So just to give you a relative magnitude of the problem, that we think these are very rare diseases, but they're actually one of the most common cause of visual impairment in the childhood and young adults, and almost 25% of the working population may have visual impairment due to IRDs, and there are more than 300 genes which have been associated with inherited retinal degenerations. So how do you take care of them? How do you go about it? The new standard of care for the inherited retinal degeneration is to early diagnosis and characterization of disease, genetic testing and counseling, and your own familiarity with the ongoing clinical trials and how update you are with all of these things. So the clinical characterization involves carefully noting down the history, the visual acuity, the perimetry, fundus examination, multimodal imaging, and electrophysiology, where visual acuity, it may just not be only the BCVA, but also the color vision, the history of night blindness, cycloplegic refraction. So many times, a lot of myopic patients are more associated with one particular kind kind of retinal dystrophies, while hyperopia may be associated with other kind of retinal dystrophies. And why perimetry? Because we know that there are conditions when your BCVA or the visual acuity may be 20/20, but the patient is still visually handicapped because the visual field is extremely constricted. Electrophysiology is a huge contributor to the diagnosis of inherited retinal degenerations, and here I'm just giving you overview of how each retinal degeneration would have a different kind of a waveform and presentation, and how this can help us in diagnosis. And most importantly, it is non-invasive, it is objective, gives you a functional dissection of the retina, and in few cases it can help you even diagnose the genotype. Wide field fundus photography is vital now because a lot of these dystrophies will actually start in the periphery. So just a posterior pole photograph, you can see if you only photograph at the posterior pole, you probably will miss out on this very important finding, which is a well-demarcated peripheral area. This is a Mirante image showing you macular atrophy as well as a well-defined area of peripheral atrophy. This is shown only on a wide field photograph. Another example of a very good investigation is fundus autofluorescence. Fundus autofluorescence is a must in cases of IRD. You can see the fundus photograph is actually not showing you the extent of disease as beautifully as a fundus autofluorescence will show, and this is because we know FAF shows where hypoautofluorescence is correlated with the death of the cell, and hyperautofluorescence is compared or associated with metabolic dysfunction. Sometimes autofluorescence can give you this pattern. So this is such a beautiful example where you see that the underlying gene is ABCA4 mutation, but typically it has peripapillary sparing of the RPE, and this is a hallmark of any retinal dystrophy which is caused by underlying defect by ABCA4. So the photograph can give you the clue. Fundus photograph and autofluorescence correlates very beautifully with OCT as well. You can see this ring of hyperautofluorescence can actually mark the boundary of the diseased area from the dying area. So this can show you that this is where the disease is now progressing. In cases of cone dystrophy, this ring goes on becoming larger and larger. In cases of retinitis pigmentosa, it goes on becoming smaller and smaller, and as it goes smaller, the tunnel vision becomes lesser and lesser. So this autofluorescence can be extremely important. Another example, this is a case of optos photograph of a patient with X-linked retinoschisis. You can see the difference between this patient and this. Here, the autofluorescence is almost completely dark, which shows that the split has involved the macula as well. So very poor prognosis. Even if you do surgery and put the schisis down, patient is not going to improve visually. So this is what I discussed, that this area of ring of hyperfluorescence will correlate with the area of preserved ellipsoid in patients with RP. This again, OCT is almost like a spotter here that you can diagnose very well. The moment you see this kind of a shaggy photoreceptors, bilaterally symmetrical disease, you know you are dealing with a vitelliform kind of a pathology. And then the prognosis. So how does it help in prognosis? It shows us that disorganization is a poor hallmark, that the visual acuity will be poor. It can pick up macular edema. Almost 30% of patients with retinitis pigmentosa can have macular edema, and this is easily picked up. Presence of hyperreflective foci are known to be associated with poor prognosis of visual acuity. The classification of genetic diseases can be done on the basis of OCT. KCNV2 is a kind of cone dystrophy which can be classified. You can see earlier there is a very small area of focal disruption, and then almost this lacuna starts appearing. This is followed by extreme atrophy. So this is OCT based classification. As I said, macular edema can be present in autosomal dominant PRPF31, and this knowledge is very important. This one was referred to us for macular hole surgery, and when I did the OCT and I did the fundus photograph, I knew this was not normal fundus, and on diagnosis and genetic testing, patient was seen to have autosomal dominant RP due to PRPF6 mutation. Good phenotyping with good ERG can actually pinpoint the underlying genetic defect indefinitely two genes. One is NR2E3 gene mutation, which causes enhanced S-cone, and the second is KCNV2, where these typical supernormal responses of combined response. One of the only dystrophies where you will have supernormal responses in presence of a poor visual acuity. So this is where it can be important. So once you have such a good phenotyping, what is the role of genetic testing? So most important, when a patient of IRD is there, you must do a family history, try to make a family pedigree to distinguish whether it is autosomal recessive, dominant, X-linked, or recessive or X-linked dominant. But whatever deep phenotyping you do, there are more than 300 genes which can cause IRD. So unless you test for them, you will not know which one is which. And this is the new standard of care. The AAO, the American Academy Task Force, has released a position almost since 2016 that all monogenetic diseases such as RP and Stargardt's must undergo genetic testing, and especially with the approval of Luxturna for LCA, these patients of LCA and RP should undergo testing, so that whatever trials are undergoing, if the patient wants to get enrolled into them, they should be tested for this. So once you try to do the testing, I'll go a little slow here because probably this area is a little new to a lot of us. There are 2-3 types of tests you can do. If you are thinking of RP65, okay, just let me see whether this patient of LCA has RP65. So you could order that I want to look for RP65. So that kind of testing can also be done. But for that, you need a working diagnosis. You must be very clear in your head that this is probably an RP65 gene defect which is causing it. But then if you go on doing this, if that is negative, you go to the next one, it will be very expensive for the patient. So the second option is something which they call gene panel. So most of the genetic testing, they have come up with a set category of say 100, 200 genes which they test when you say a patient has IRD. And then most common diseases, most common genetic tests, gene mutations will be tested. So you would think, why not check the whole genome? If we check the whole genome, it is more expensive, more time consuming, more laborious, and may not always give you a more useful information. So the gene panel testing is one of the best ones. And why do you do it? You would say that there's no treatment for it. What will I do if I know the gene? No, it helps you confirm the diagnosis. In a lot of cases, you will not know whether it is toxicity, whether it is inherited. So it helps you confirm diagnosis, allows you a proper genotype-phenotype correlation, very important for prognosis. Autosomal dominant RP, as I said, PRPF6, you saw a patient was 50 plus and yet had reasonably good vision. She's not blind. She just came incidentally for a checkup. She had no history of night blindness. So you know how this is going to progress. Which are the severe forms of disease where the child will really become progressively blind, where the parents need to be careful for the next child, whether they really want to have another blind child or not. Rule out syndromic disease. You may be the first one to pick up the disease from the eye point of view, and yet the patient may have a kidney problem, heart diseases. So all that, it helps. Giving you an example, we had recently published the genotype-phenotype correlation of circle mutation causing RP. This helped me diagnose this patient. I saw this patient recently, 35-year-old, and he was just diagnosed to have bilateral myopic degeneration. But I saw these coin-shaped lesions in the periphery, and immediately I thought of circle, asked for a genetic mutation. Patient was circle positive, and circle mutation causing RP is one of the most common mutations in northern countries, so I'm seeing this more often. But that doesn't always hold true. This is a patient I again saw recently. Everybody knows this is retinitis pigmentosa, but did not pick up the gene. So you need clinical correlation and genetic testing both together. So these are just some few examples. I think because of paucity of time, I'll just quickly wrap up. So this is another, as I discussed, it is useful to tell us the underlying syndrome. But then you may have Best disease, one single mutation causing various spectrum, and it may not always, it can be benign, something like vitelliform, or it may be autosomal recessive bestourinopathy, which can be visually blinding. We all know ABCA4 can give you Stargardt's, ABCA4 can give you cone rod dystrophy, it can give you retinitis pigmentosa as well. Then there is something called phenocopies. So just like one disease, one mutation can give you various phenotypic presentations, various genetic diseases can give you a similar, genetic mutations can give you a similar kind of phenotypic presentation. X-linked retinoschisis, highly phenotypic. We know we have milder varieties, we have severer varieties, and then here, whether it's a missense mutation, kind of mutation will probably help. Most importantly, the genetic testing comes with a responsibility. You must have a genetic counselor. You must discuss these things with the patient, not only after the test, but before the test as well. So this is very important. Coming to the algorithm. So what do? The patient comes to you in the clinic. I think from my talk, now you should be clear with the algorithm. You take the history, you do a detailed clinical examination, and then multimodal imaging, functional assessment, multimodal imaging, wide field imaging, FAF, OCT. So these will help you diagnose, these will help you know the prognosis and the progression. And similarly, functional assessment, full field ERG may not help you with progression, so you may have to do multifocal ERG or a newer test called FST. And so these, after that, the genetic testing, once you do genetic testing, you will have to go in for genetic counseling. This can be pre-test and post-test, and clinical geneticists should be present. And to those of us who may think that we don't have a geneticist with us, how do we do? Even a telephone-based genetic counseling is acceptable. So you can have a virtual counseling also done for the patient. So to conclude, deep phenotyping is necessary, but genetic testing is also important, and establishing a genotype-phenotype correlation is extremely useful as new therapies come in. So precise phenotype genetic workup is a must for any patient to enter a clinical trial. Thank you for your patient hearing.
Thank you, ma'am. And there's a brilliantly organized talk. I think we can take the questions later. We're running short of time. I'd like to invite Dr. Rajiv Raman from Shankar Nethralaya to talk about his algorithm approach to manage diabetic retinopathy.
Can you put my talk on? Already uploaded. Next few minutes I'll be sharing. We'll be going through approach of one of the very common disease. You have seen many of these retinal diseases which are not as common as diabetic retinopathy. There are some guiding principles in treating diabetic retinopathy. The first thing you do is you classify it into a sight-threatening versus non-sight-threatening. What is sight-threatening? Anything less than moderate. What is non-sight-threatening? Anything less than moderate is a non-sight-threatening. Severe NPDR, PDR, and macular edema comes under a sight-threatening diabetic retinopathy. You consider doing investigations, sometimes fundus seen angiogram, OCT, OCTA, ultrasound, wide field imaging, whichever is needed. And for proliferative disease, PRP is a mainstay of treatment. You classify diabetic macular edema into a center involving or a non-center involving diabetic macular edema. Again, glycemic control, the control of BP, lipids, anemia, they are very crucial. And anti-VEGFs are still the first line of treatment in center involving diabetic macular edema. You can switch anti-VEGFs, switch to laser, switch to steroids if it is a non-responder or a poor responder diabetic macular edema. OCT and vision are the key tests to determine the initial treatment choice, and also you want to see how the response of the treatment is coming. So on follow-up, these two are important. And in case where there is vitreomacular traction, in select cases of non-responding DME, you also have a role of vitrectomy. So these are certain guiding principles whenever you are thinking of managing diabetic retinopathy. Let's talk about two sight-threatening conditions, DME and proliferative disease. So if it is a DME, you first see whether it is center involving or not. So if there is more thickness in the central subfield, so you can define center involving by two ways. One is based on thickness, one is based on lesions. So if you get more of cystic fluid or any of the diabetic lesions, retinopathy lesion in the central subfield of your OCT, you can call it as a center involving DME. Now, how to treat it? So you can see this non-center involving DME. It can be a treatment nearby, or it can be even after injection. So patient was already on injection, comes to you, and you have the central edema is not there, but paracentral edema is there. You look into vision. Anything good vision you tend to observe. Laser is still a mainstay as far as non-center involving edema is concerned. Very recently we have published that we followed these non-center involving for 2 years. A third of them, nearly 26% of them, convert to a center involving in 2 years. And the only risk factor is longer duration of diabetes. So if you have people with longer duration of diabetes, be more watchful for this conversion. If it is center involving, you look into vision. Anything good vision, 6/9 or better. Protocol V of DRCRnet taught us that no need to treat them, you can observe. And if it is worse, anti-VEGF injections can be started, intravitreal injections. Usually we continue for about 3 months and then determine whether it is a good responder or an intermediate response or a poor responder. So this again depending on the anatomical response and the visual response, you take a call. Good responder, you can continue anti-VEGF. It's a partial responder, you can still consider continuing. If it is poor responder, you can switch to another agent, or you can think of using a steroid. How to determine which one to do? There are certain patient-related factors you can take into account. So if a person had a recent history of cerebrovascular accident less than 3 months old, you avoid using anti-VEGFs. You can consider steroids. You can also consider laser. If it is a pregnancy DME you see in pregnancy, mild edema, you can still watch with a good vision. If vision is poor early in the pregnancy, laser or steroid can be considered. Late in the pregnancy, if you get a center involving edema with a poor vision, no need to treat. After the delivery, the edema will automatically reduce. So poor compliance, again, these are the cases you can think of giving a little longer acting newer anti-VEGFs or probably steroid. If a person is of a chronic kidney disease, many times we do have these patients, you start with anti-VEGF and during treatment do monitor that how his eGFR is. If it is worsening, you can give a break and then continue again. There are also some eye-related factors which govern what agents to use for DME. So if you have a vitrectomized eye, you know that the vitreous sump is not there. These are the cases. If it's an early edema, you can still watch. If it is late, steroids probably do better in terms of less number of injections. Equal anatomical results have been shown with anti-VEGFs too. However, they need much more injections as compared to steroids. If it is diabetic macular edema with proliferative disease, anti-VEGF is the first choice. You can do PRP, or you can even do a deferred PRP, meaning that you give an anti-VEGF and then followed about a couple of weeks later completing your PRP. If it's a pseudophakic eye with DME, it's important to differentiate whether you're dealing with a pseudophakic or diabetic, or they have both the components. Both have to be tackled together. You can consider steroids in these cases as an initial choice too. There are some disease-related factors. So we had patient-related, eye-related. There are some disease-related, like you have plaque of exudates. Again, important to control dyslipidemia. Intravitreal steroids have shown that they reduce it much more quickly. However, vision-wise, you have to be guarded because even if they resolve, they cause an area of atrophy. A poor vision or a thicker retina, you can consider the newer drugs, Eylea or faricimab, and even intravitreal ranibizumab works well. If there are vitreoretinal surface abnormalities, these are the ones you must understand. Anti-VEGF still can work, but they need more injections. You can consider steroid, and if it is not responding, vitrectomy is the choice. And then you start assessing the response, and if there is a poor systemic control, if it's a poor responder, definitely look for poor systemic control and do appropriate referral. it's good to identify the best response from the history, because many times they say initial injections worked well. Try to consider the same drug when you're switching. And if it's a chronic edema more than 6 months, again, not responding, steroids can be considered. And again, if there is some drug history, there are a couple of these drugs which can cause which can cause macular edema. And if they are on these drugs, definitely you want to stop it, and that will help resolution of the macular edema. So this is the algorithm. I'm not going in detail, but exactly what I spoke is covered in this small algorithm. Coming to managing proliferative disease, again, as I told you, panretinal photocoagulation is the mainstay of treatment. However, in certain situations, you can change. If you have diabetic retinopathy with a single NVE, good compliant patient, you can consider monotherapy with anti-VEGF2. However, if it's a poor compliance, definitely go ahead with PRP. If there is no traction and the patient is again a good compliance patient, you can consider anti-VEGF and later on do a PRP. If there is traction not involving fovea, you tend to do a panretinal photocoagulation about 2 disc diameter away from the areas of TRD, otherwise you will convert it to a combined retinal detachment. If it is with center involving DME, you do anti-VEGF with PRP. If it's active PDR, even despite your complete panretinal photocoagulation, you assess the size of the vessel, whether they are mature vessels or still immature vessels. Mature vessels, you can wait. If it is immature vessel, you go ahead doing a supplemental PRP. And if there is PDR with NVI, you need to really be very aggressive. Don't wait for a PRP response of 3 months. Call again after 2 weeks. You want to do a more aggressive PRP as compared to a normal PDR. So the success of treatment in diabetic retinopathy is not just anti-VEGF, not just steroids, but a very good control of systemic factors. Most important is a good compliance to follow up and a good compliance to treatment. And you must understand the patient's journey. It's not getting over, it's a lifelong journey. He has to be with you. Thank you very much. I would like to invite all of you for the 6th Retina Summit and IROP meeting. Thank you, Urmi.
Thank you, Dr. Rajiv, for that. It was well put up, well organized slides and presentation. Thank you so much. I'm inviting Dr. Vishnu, running short of time because we got the hall late, but just Dr. Shane Matthew, the retinal specialist from Chaitanya Eye Hospital, will be talking to you about the algorithmic approach in retinal venous occlusions.
We started 15 minutes later only. We were standing outside.
While the talk's getting loaded, I've made this presentation in a slightly different way. So we all know about the algorithm on managing retinal venous occlusions, and what changed? I thought I'll just speak before it starts because of lack of time. So we know about the algorithm in venous occlusions. You see neovascularization, you start treating them. You have macular edema, you started treating them. This is what we have been knowing for all these years. So what has changed now? A larger area of peripheral capillary non-perfusion, what we normally could thought it was. This led to the concept of ISI, to note the ischemic index. What it means is, when the ischemic index was larger, there was higher risk of neovascularization, and the ischemic index is smaller, the macular edema responded well. The progression of retinal ischemia was more in the first year, almost 16.3%, and there was a progressive reduction in the coming years. That means we need to follow up this patient aggressively for the first year. Non-perfusion anterior to the equator was strongly associated with macular edema in retinal vein occlusion. The patient with ischemic index less than 10% had a greater amount of retinal thickening. So what it finally shows is ischemic index is a strong indicator, a prognostic biomarker, and it causes reduction in the area of PRP because we're going to give a targeted panretinal photocoagulation. And how this may change my practice, my tendency is towards doing an ultra-wide field fluorescent angiography, especially in retinal venous occlusions, as the baseline, and probably following them up with an OCT angio. Intravitreal pharmacotherapy has been the cornerstone in managing macular edema. Anti-VEGF is still the first line of management. The second line would be steroid unless otherwise indicated. laser photocoagulation for neovascularization, and also in cases of recalcitrant macular edema to see as a last resort to do laser in the periphery to see whether macular edema is resolving. Surgical intervention for vitrectomy in vitreous hemorrhage and retinal detachments, radial optic neurotomy, sheathotomies, tissue plasminogen activated injector all had good results in few studies, but is not considered as the standard of care in managing these diseases. Combining anti-VEGF along with laser treatment had good results in many of these studies, so we may use this and another armamentarium. A word on neovascular glaucoma. There is a concept about a labile disc, the disc being very labile to intraocular pressures, especially in neovascular glaucoma in RVO patients. So that means to say, we used to treat with anti-VEGF, do laser, wait for the laser to get it action, and then start treating a non or intractable glaucoma. The times have changed. Filtering surgeries have got very good results, especially glaucoma implant. So the target should be to immediately bring down the IOP so that the disc doesn't get shut down. And then probably you can add on with photocoagulation or even anti-VEGF therapy. Regarding intravitreal pharmacotherapy, we now know 5-year results, 50% of these patients still need further injections. So there should be strategies to change or revamp the way we inject these patients. So according to this, we can stratify patients after the 3 loading dose into the non-responders, responders, and partially responders. The non-responders, you keep injecting. The partially responder cases, you give injections for 6 months and then reassess. And the responders, we directly go into a PRN regimen. The advantage is we are able to reduce the number of injections and follow them up in a much better way. To take home, OCT angio, and ultra-wide field imaging has become integral part of RVO management for me. ISI is gaining interest, and the role of peripheral laser photocoagulation. And last but not the least, stratification of patients who need pharmacotherapy to reduce treatment and follow-up burden. Thank you very much.
Thank you, Dr. Shane, for that talk on the algorithm approach to RVO. We'll have the last talk of the session, and that is Dr. Sunil from Davangere Nethralaya talking about prognostication in surgical macular conditions.
Good afternoon, everyone. So let me cover some of the surgical macular conditions and how to prepare an algorithm for management of such cases. So I'll be covering some of the commonest surgical conditions one tends to see. Either it could be form of a full thickness macular hole or lamellar hole, ERM, vitreomacular traction, myopic tractional maculopathy, and subretinal hemorrhage. When you see a case of a full thickness macular hole, either you look at the age of the patient, the duration of the macular hole, the presenting best corrected visual acuity, what could be the etiology of the the full thickness macular hole. Obviously, looking at the spectral domain OCT features and the prognostic indices like macular hole indices, which I will be discussing one by one. The SD-OCT basically helps in diagnosis, staging, prognosis, assessing the tractional forces, either tangential or anteroposterior tractional, and monitoring the closure, whether what type of closure has occurred post-surgery. Hole size is a very critical factor. As we know, the lesser the size of hole, which is less than 400 microns, tends to have a better prognosis than the large size holes, which tends to have a poor prognosis. Many biomarkers have been studied on a full thickness macular hole. Some of the important thing being the mean linear diameter, basal diameter, height, the configuration of the hole, whether it has got a flat edges or the presence of subretinal fluid, what we call as a macular hole angle. Then there is a vitreomacular traction, epiretinal membrane. Look at the external retinal layers also and the supra-RP granular deposits. Many indices have been considered, among them the most important being the tractional hole index, then the macular hole index, and the mean lid diameter. I'll be telling in the subsequent slides. But the key thing about these indices is some of the indices looks at both the tractional forces, the tangential and anteposterior, some into some of them. Among them, the most important one are the hole forming factor and the macular hole indices, which takes into account both the tractional forces and as well as the anterior posterior as well as the tangential, which gives a better prognostic value when compared to the other indices. Similarly, the macular hole imaging thing, if you incorporate an image software, we can calculate something known as total area. This is a total area, and this is a macular area, the tissue area. And even you can calculate the cystoid area. Based on that, certain indices can be calculated like macular total area index, macular area index, and the cystoid space area index also can be calculated, which has got a prognostic value. Some indices helps in detecting the type 1 closure and some in the type 2 closure. The macular hole indices, tractional hole index, macular cystoid space area index basically very well correlates with the type 1 closure. The opening diameter hole index and the macular area associated indices helps in prognostication type 2 closure. Please look at this photograph. The external retinal layers are very, very critical for the prognostic point of view. Like this, it's got a very good closure with the retention of all the external retinal layers. This patient tends to do well, and compared to these patients, in spite of closure, they may not do well because of the atrophy of the external retinal layers. The microperimetry is another important thing which helps in assessing the retinal sensitivity in these patients. So one need to look at the functional assessment also rather than the anatomical closure. Octa, definitely studies have shown that there is a significant correlation between vessel density of the superficially capillary plexus and the deep capillary plexus with respect to the visual acuity as well as the retinal sensitivity at 1 year. FSZ enlargement may be a potential biomarker for foveal reconstruction after foveal full thickness macular hole, but sometimes the FSZ evaluation may be difficult, especially because of the presence of the intraretinal cyst. So, but FSZ also can give a clue to the prognostic aspect of the closure of the surgical techniques. There are many surgical techniques have been described based on the size of the holes. The ILM peel and ILM flap works for the mild to moderate sized holes. The macular hydrodissections, human amniotic membrane and autologous retinal transplantation works for the larger sized holes. ILM peeling, definitely ILM peeling works well for the small to medium sized holes. ILM flaps also can be considered for larger holes, but one need to look at if somebody has got a macular hole index of less than 0.5, larger ILM peel should be done for a better outcome of the surgery. As we know, the things like human amniotic membrane and autologous retinal transplantation may give a good anatomical success. Sometimes the best corrected visual acuity may not be as good as, and the functional recovery may not be good, but you may get a good anatomical recovery. So coming on to the surgical algorithm, when you see a case of a full thickness macular hole, what all things to be considered? One is the size of the hole, as I told. The other thing, you can consider the axial length into the thing. Then whether it is a first operation or a re-operation, one should see. Sorry. If it is a re-operation, please see whether it is a fluid cuff at the lifted edges or the flat edges, which gives a clue what should be the management procedure. If there is a fluid cuff is there, then the office fluid gas exchange may help in the closure of the hole. If it is the flat edges, some can do in perifoveal hydrodissection. So if there is a larger axial length is there, probably one can resort to an aggressive maneuvers like scleral imbrication or a macular buckle. But large sized holes, ART and amniotic membrane works well. Coming on to the lamellar hole, there are two sorts of lamellar hole. Basically, one is called tractional lamellar hole, the other is a degenerative hole. In a tractional lamellar hole, there is a split typically seen at the level of outer plexiform and outer nuclear layer. These patients, if they are symptomatic, may sometimes respond to the surgical treatment. Unlike degenerative holes, which may associated with lamellar hole, epiretinal proliferation and other, these tends to do poorly when compared to the tractional holes. So surgery can be considered in lamellar holes if there is a moderate to severe visual impairment. If there is a metamorphopsia and the outer retinal layers are intact, one can consider, especially in tractional holes, surgical maneuver. Coming on to the ERM, consider the age of the patient. The younger the patients, better. Pseudophakic patient does better than the phakic patient. Low baseline visual acuity is a poor prognostic factor. Less than 1 year, they tend to do well. The metamorphopia score definitely tends to correlate with the visual acuity. In the ERM, basically look at the stage of the macular hole, which indicates there is an entity which has been described as a ectopic inner foveal layers and the retinal layers. These two entities, if they are present, it indicates a poor prognosis. So stage 3 and stage 4 holes responds poorly to treatment when compared to the stage 1. Suppose the contour of the macula also, if you tend to see a dome-shaped macula, they tend to do well when compared to the flat or a depressed macula. Look for the pit contour recovery post-surgery, which gives a clue. If you have got an early pit recovery for contour recovery, they tend to do well when compared to the other patients. Another entity which has been described, what is known as inner retinal irregularity index, which is also a surrogate marker which tends to correlate with the visual acuity and metamorphopsia score. So one need to look into that. As I told before, the most critical entity in ERM surgery is ectopic inner foveal layer. If you tend to see in presence of an ectopic inner foveal layer with advanced stages, they tend to do poorly, especially in stage 3 and stage 4 holes. I told, look at the outer retinal integrity, not only the inner retinal integrity, they also seems to correlate with the visual acuity. Central bokeh abnormalities is another abnormalities which tends to see in all sets of tractional maculopathy. They also correlate with the worse visual function if you tend to see with along with the ectopic inner foveal layer. The drill is another entity which is seen in other many conditions like diabetic macular edema and all. This is also another surrogative marker in ERM surgery. Shorter the axial length associated with ERM tends to do poorly when compared to the longer axial length. If you tend to see a microvascular leakage associated with an ERM and an FFA, they tend to do poorly when compared to the eyes which doesn't have a microvascular leakage. OCT angiography, definitely foveal and parafoveal vessel density is a positive prognostic factor for post-op visual acuity and macular sensitivity. Some cases, post-surgery, you may not see a typical FSZ expansion post-surgery. These patients tends to poorly in spite of a removal of the ERM. Choroid, if you look at the saddler layer perfusion is one of the prognostic factors which have been shown to be associated with good functional recovery. So as I told with ERM surgery, older the age, longer the duration of symptoms, lower the presenting visual acuity, higher the metamorphopsia score, thicker the central foveal thickness, thicker the ganglion cell layer, and the inner nuclear layer thickened, and the photoreceptor outer segment if they are shorter, ellipsoid zone being irregular, and the presence of ectopic inner foveal layer, all these are poor prognostic factors when you're considering an epiretinal membrane surgery. Coming on to the vitreomacular traction, usually the end sequence of vitreomacular traction is either by spontaneous recovery or they progress to a full thickness macular hole. And what are the poor prognostic factors in a VMT or vitreomacular traction? One is the longer duration, preoperative best corrected visual acuity of less than 660, preoperatively thick central macular thickness, somebody who has got an associated premacular fibrosis, associated schisis and CME, these are the poor prognostic factors in VMT. So if you see a VME, you can just observe. If you see a VMT with asymptomatic and every 3 months you can follow up. If there is a associated ERM which is a thin ERM with a less than 1500 microns, can sometimes respond to the pharmacological vitreolysis. But with EMT and with ERM, if there is present and if the ERM is more than 1500 microns, you need to resort to a surgical maneuver rather than doing a pharmacological or an observation maneuver. Last entity, there is a myopic traction maculopathy. Either you tend to see a schisis or a macular associated detachment or macular holes. So what are the treatment options for myopic traction maculopathy? Either you observe or do a macular buccal or a pars plana vitrectomy or scleral implication. I'll find up, okay. Okay. So if you see stages of the myopic traction maculopathy, if you see a stage 1 and most of it is observation, and stage 2 end stages you may have to resort to macular buccal or pars plana vitrectomy along with the ILM flaps. Macular buccal does do well in cases of stage B holes in the myopic tractional maculopathy. And the last thing about subretinal hemorrhage, look at the duration of the submacular hemorrhage, look at the etiology of the submacular hemorrhage and the size of the submacular hemorrhage. If it is a small submacular hemorrhage, you can give an anti-VEGF alone. If it is a medium, you can use an pneumatic retinopexy in the form of expansal gas along with the TPA and anti-VEGF. If it is a medium, you can do a pars plana vitrectomy with subretinal TPA. And if it is a massive, probably external drainage and the displacement with the residual hemorrhage and the intravitreal TPA also can be combined with this. So you have to plan the subretinal hemorrhage according to the size, duration and the age of the patient and the etiology of the patient. Thank you. Thank you for your patience.
Thank you, Dr. Sunil, for that extensive algorithm. We're short of time, so concluding the session, I'd like to thank everybody for being here and thank our next chairman moderator for the patient zone. Thank you.